Chapter 46 will discuss sexually transmitted infections. STIs are a broad range of infectious diseases that are typically spread by sexual contact. Some of these diseases are mandated to be reported to the CDC, which I think is a good thing for you to know. This includes chlamydia, syphilis, and gonorrhea. The rest of the STIs may have state level requirements for reporting, but not always. But these three for sure do need to be reported to the CDC. One thing with STIs that makes them very difficult as far as preventing spread is that many of them, as you'll see through this discussion, are asymptomatic. Many people carry these diseases, or the symptoms are relatively subclinical, where they don't notice that there's anything going on. And so they continue to carry and spread these diseases without knowing that they have them. And the viral STIs, things like herpes and HPV, there are really no cures for these viruses once someone is infected. And with the bacterial related STIs, things like chlamydia, a lot of the microorganisms that cause those diseases are also becoming resistant to the drugs that we've typically used to treat them. STIs can have significant consequences in pregnancy. And so we'll kind of talk about that as we address each one. But things like stillbirth or prematurity, low birth weight, sepsis, pneumonia, congenital deformities, as well as those STIs being transferred to the baby during birth. So one of the learning objectives for the course was to identify some of the microorganisms that are responsible for certain STIs. So here they are. Condylomata acuminata, which is genital warts, is the human papillomavirus. Genital herpes is herpes simplex virus. Cancroid, which we're not going to talk about, and granuloma inguinal, they're bacteria that spread them are here. These are two STIs that we don't really see much in the United States, as well as these Klebsiella and H. Ducrey. These are STIs that are more prominent in developing countries. But we will discuss chlamydia trachomatis as well. So when we talk about STDs, there are multiple portals of entry. So they can enter the body through the mouth, genitalia, urinary meatus, rectum, and for some, like I think syphilis can actually enter just through abraded skin. So we'll start with the STIs of the external genitalia. And so this includes HPV or human papillomavirus and HSV or herpes simplex virus. So HPV infections, we talked about these a little bit when we talked about cervical cancer, but we'll go into it a little bit more. HPV are really the most common STI. There are over 40 different types, as we mentioned, of HPV strains. 20 million Americans carry the HPV virus. Risk factors include age, so typically infections happen before the age of 25. Early onset of first sexual intercourse increases risk, and multiple partners also increases risk of HPV infection. Most of these infections, though, are asymptomatic or transient, meaning they resolve spontaneously, and someone, is able to rid themselves completely of the virus as long as their immune system is entirely intact. But there are some high-risk strains of HPV. So infection with certain HPV types will result in genital warts, potentially in cervical dysplasia, and eventually in cervical cancer. So HPV 16 and 18 are two strains that are strongly associated with cervical dysplasia and anogenital cancers. But only, even though they are, much higher risk, only a small percentage of people infected, even with these high-risk strains, will develop cancer. So there are some cofactors that can increase a person's risk of developing cervical cancer, So these are things like smoking, immunosuppression, and hormonal alterations that include things like pregnancy and the use of oral contraceptives. So the pathogenesis and clinical manifestations of HPV, the incubation period for HPV induced genital warts is anywhere from 3 weeks to several months. So that means from the time that a person is infected to the time that they would show symptoms can be anywhere from 3 weeks to several months. Cervical abnormalities, the incubation period there would be several months. So after infection, cervical cancer can take decades to occur from an HPV infection. So usually the clinical manifestations of HPV are things like soft raised fleshy lesions on the external genitalia. There are a lot of different shapes and types of lesions that someone can experience with HPV, and it's often driven by the strain of the HPV infection that they have gotten. So there also can get these kind of more cauliflower shaped lesions, and those typically occur on the mucous membranes in the vagina, urethra, anus, and mouth. So sometimes the lesions look a little different depending on what type of tissue they've infected. 70% of women who become infected with HPV become what we call DNA negative within 1 year, meaning that there's no longer any sign of that infection in the body. 90% will become DNA negative within 2 years. So again, the vast majority of people are able to, with an intact immune system, resolve these infections on their own. But the other thing about an HPV virus, it can remain dormant in the body, showing no signs and symptoms, and it can reactivate at a later time. So someone could experience a recurrence of genital warts, cervical dysplasia, or cervical cancer, even years after infection. So the diagnosis, prevention, and treatment of HPV, we do have HPV DNA tests now, and we often use those along with Pap screening to determine risk of cervical cancer development. There are 3 vaccines for specific HPV strains, and the recommendations are to give 2 doses of HPV vaccine. If you're doing this before the age of 15, we give 2 doses spaced about 6 to 12 months apart. The recommendation is that these really start at 12 years of age. If someone has not been vaccinated for HPV and they're past the age of 15, so maybe between the ages of 15 and 24, we recommend 3 doses of HPV vaccine for that particular age group. There is no treatment once someone is infected with this virus, and prevention of HPV through condom use has not been adequately demonstrated. So people are still able to sometimes pick up this virus despite condom use. And the treatment goals once someone is infected is really surveillance for malignancy is the kind of primary goal here. Now we'll move on to genital herpes or herpes simplex virus. These are also very common. Current estimates are about 16.2% of the population infected with HSV, but those are probably underestimates because this particular STI is not one that's reportable to the CDC. And so not all states have reporting requirements around HSV. So it's really hard to determine the exact numbers here. So again, that's probably a significant underestimate. Women tend to be at greatest risk of developing and becoming infected with HSV virus just because they have a larger mucous membrane kind of surface area in the genital region, increasing, the amount of area that the HSV virus can infect. There are many different types of herpes viruses. There's the neurotropic alpha group viruses, and these are kind of our classic herpes simplex type 1 and type 2. Varicella zoster is also a herpes virus. That is the virus that causes chickenpox. And then there are also something called lymphotropic beta group viruses. So this is cytomegalovirus, Epstein-Barr virus, and human herpes virus type 8. Cytomegalovirus and Epstein-Barr virus, again, these are lymphotropic. So these are also 2 viruses that are commonly associated with virus-induced lymphomas that we had talked about previously. Lymphotropic beta group viruses include cytomegalovirus, so that causes cytomegalic inclusion disease. Epstein-Barr causes infectious mononucleosis and Burkitt's lymphoma. And human herpes virus type 8 is the most likely cause of Kaposi sarcoma, which was the type of skin cancer that we often see in patients with AIDS. So the pathogenesis of genital herpes infections. So these viruses replicate in the skin and in the mucous membranes right at the site of infection. So either in the oropharynx or in the genitalia. Neuropathic viruses can also grow in neurons, and they share the biological property of latency, meaning both HSV1 and HSV2 can go into these what we call latency periods, meaning that they can go dormant in the body, in the cells that they're infecting, and reemerge later on to cause a recurrence of an infection. We're not going to talk too much about varicella zoster, but you see that latency in that disease as well in the later reinfections with things like shingles in people who have had chickenpox. In genital herpes, that virus ascends through the peripheral nerves. So it infects into the skin, it gets into the peripheral nerves directly in the skin, and it travels up the nerve to that sacral dorsal root ganglia. And then it kind of can go dormant or latent within that nervous tissue. And during that dormancy or latency phase, the way that the virus is replicating during that time makes it difficult for both the immune system and for any available antiviral treatments to have any effect on it. So it's very difficult to treat anything within that latency period. But then the virus can reactivate and travel back down those nerve roots to the skin again and cause new lesions. And the host response to infection really influences both the initial development of the disease and how severe it is, or if there's any development of lesions at all. It also is closely associated with the development and maintenance of latency periods. So people with stronger immune systems are able to better maybe keep that virus in a latency period, and they don't maybe experience as much recurrence of the HSV infection. So this disease causes vesicular lesions right at the site of infection. And it's often not known what necessarily might reactivate that virus, but usually we would assume it's the body's defense mechanisms are altered at that point, maybe by stress or by another infection, allowing that HSV virus to reappear. So a little bit more about HSV pathogenesis. So again, it's transmitted via contact with infectious lesions. The HSV2 virus can actually be passed on to an infant as well during childbirth. HSV2 does tend to cause many subclinical infections, meaning that someone probably doesn't even know they're infected. But people can shed the virus even if they're asymptomatic, allowing them to spread this disease unknowingly. And this unknown transmission has really caused herpes to start reaching epidemic levels worldwide. The typical incubation period of HSV virus is about 2 to 10 days. So we typically see if someone is going to develop lesions, that those lesions appear within 2 to 10 days of infection. So clinical manifestations of diagnosis and treatment of genital herpes. So the first episode or outbreak of genital herpes is usually the most painful with the most obvious lesions and really the most viral shedding. Usually there's kind of a prodromal sort of feeling to the outbreak of a herpes lesion. So people experience kind of this tingling, itching, and pain in the genital area. And then after that, they get these eruptions of small pustules and vesicles that can then rupture to form these sort of wet ulcers. These ulcers tend to be extremely painful, especially when touched or any contact. And eventually these lesions will kind of crust and heal over and recede. But as we mentioned, that virus can be living in the nervous tissue, causing recurrences later. Um, but recurrent infections are usually more mild with less lesions, less pain than that initial infection. We diagnose this typically based on the symptoms, so looking at those lesions, and then we can do swab testing and PCR to verify the presence of the HSV virus. There is no cure for genital herpes. It is a viral infection, but antiviral drugs like valcyclovir can decrease the frequency of recurrence. They can also shorten the duration of active lesions, and they can reduce the number of new lesions. Okay, so now we're going to move on to sexually transmitted vaginal infections. So we're going to talk about candidiasis, trichomoniasis, and bacterial vaginosis. So candidiasis is caused by a fungus or yeast-like fungus called Candida. Its most commonly identified species is Candida albicans, but there are two other types, Candida glabrata and Candida tropicalis. Those have also been known to infect and cause symptoms. Um, Vulvovaginal candidiasis is actually not necessarily transmitted sexually, but we include it in CDC-related STI treatment guidelines because it's often diagnosed in women who are being evaluated for STIs. So healthy women, 20 to 55%, have candidiasis in the vaginal area without causing symptoms. But most likely what's happening here when candidiasis becomes infectious is that there's some sort of alteration of the host's vaginal environment that causes that organism to become pathologic. And that's why it's associated with things like STIs. If a woman becomes infected with an STI, that can often change that environment to have kind of a co-committant kind of candida infection as well. Other causes of candidiasis, antibiotic therapy is commonly associated with candidiasis because the use of antibiotics can suppress the normal bacterial flora in the vagina, which is protective against candida infections. This can also happen during pregnancy because of high hormonal levels. The use of oral contraceptives can also increase the risk of candidiasis because it increases the amount of glycogen in the vagina, so more kind of food for the fungal infection, as well as diabetes and HIV infection because they can both compromise the immune system and allow this kind of opportunistic infection to take hold. So diagnosis and treatment of candidiasis, we usually verify the diagnosis. A lot of it is by signs and symptoms, things like rash and discharge, but we can verify that diagnosis by finding spores on a wet mount slide. We use antifungal treatments, and they're quite effective in the treatment of candidiasis. So these are your typical yeast infections, and many women have recurrent yeast infections. They're aware of the signs and symptoms. And so because of that, many of the treatments for these, things like topical gels and creams, are available over the counter, even without a prescription, so that women with recurrent candidiasis infections are able to self-treat. Now we'll move on to trichomoniasis. This is often called trich. The reason I have turnips here is because the protozoa that causes this disease is apparently turnip-shaped, so that's why they're here. But this is a anaerobic, so non-oxygen needing protozoan that feeds on the vaginal mucosa and ingests bacteria and leukocytes in that area. So the symptoms of trich are copious amounts of frothy, malodorous green or yellow discharge. If somebody has trich, you cannot miss it. It is one of these infections that once it takes hold, the amount of discharge and the odor that it causes is very apparent. There is also erythema and edema of the affected mucosa. There can be itching and irritation, and sometimes these kind of strawberry red spots also start to appear on the cervix. This can cause several complications. Men harbor this organism, so they harbor this protozoan within their urethra and their prostate. But men are generally asymptomatic with trich. So when a woman becomes symptomatic with trich, we track back to their sexual partners to try to find the male partner who's just carrying this protozoa really unknowingly. An infection with trich will increase the likelihood of HIV transmission in both men and women because it's a protozoan and it can almost, the HIV infection can kind of attach itself to that protozoan and it helps to move that infection across the mucous membranes. Trich also increases the risk of things like tubal infertility, and it can cause sort of an atypical PID in women. It's associated with premature birth, and as I mentioned, it serves as a vector for the spread of other organisms, other bacteria, other viruses that can attach to its surface to aid in their infection. And it can also be, even though men are asymptomatic, it can increase their risk of infertility. So diagnosis and treatment. So as I mentioned, somebody who has an active infection, it's pretty obvious by signs and symptoms what it is, but we can further verify that through microscopic identification of the protozoan, and that may also be necessary in male carriers who are asymptomatic. We use systemic treatment with metronidazole or tinidazole. We use systemic treatment because these organisms reside in other structures beside the vagina, meaning that we can't really do a local application of any of these treatments because of the systemic appearance of these protozoan. Symptomatic, as I mentioned, it's symptomatic in women. So the treatment should also include identification of any sexual partners so that we can track down and treat the asymptomatic male as well to prevent further spread. And we typically recommend abstinence throughout the time of treatment until the full course of treatment is completed. Now we'll talk about bacterial vaginosis, its pathogenesis, clinical manifestations, and treatment. So when bacterial vaginosis occurs, this is happening because there's a shift in vaginal flora from the typical lactobacillus species that we see there to this big overgrowth of other organisms. And usually this massive overgrowth are vaginal anaerobes. And so this creates this kind of thin grayish white discharge that has a foul kind of fishy odor. These anaerobes create something called amines, and that's what's responsible for the odor. Signs and symptoms are things like burning, itching, and erythema. Burning, itching, and erythema are usually absent, because these particular vaginal anaerobes have really low inflammatory potential. So without that inflammation, we don't get those typical signs of inflammation. But this can increase PID risk, preterm labor, premature rupture of membranes. We treat this with either oral metronidazole or vaginal gels when indicated. The other thing to mention here is that we call this vaginosis instead of vaginitis, remembering that vaginitis would indicate inflammation of the vagina. And because, as we mentioned, this doesn't cause a lot of inflammation, that's why that name changes to vaginosis. The cause of why this big shift in flora happens is really not very well understood, but that's essentially the kind of underlying cause here. So now we're going to move on to STIs infecting male and female, both genital and some extragenital structures. So structures around, but not only uh, you know confined to the genital area. So these are things like chlamydial infections, gonorrhea, and syphilis. So chlamydial infections, these are one of the most prevalent STIs in the US. The rates are probably twice what is reported. Remember, this is one of the infections that has to be reported to the CDC. So while we have decent numbers, a lot of folks carry chlamydia or receive treatment in ways that doesn't allow its reporting. So usually these rates that we see are typical underestimates. The highest rates of chlamydial infections that we see are in women ages 19 and 20 years old. It's caused by C. trachomatis, which is an intracellular, so intracellular, inside the cell, bacterial pathogen. This bacteria is much smaller than typical bacteria, and it has some similarities even to viruses, one of them being an intracellular organism. But it does remain susceptible to antibiotic treatment, so this is an infection that we can cure. So clinical manifestations, diagnosis, and treatment. So your book says, unlike gonorrhea, the chlamydia can often be asymptomatic, although when we get to gonorrhea, it also says gonorrhea can be asymptomatic. So I guess my takeaway here is that chlamydia probably tends to be asymptomatic more often than gonorrhea does. What we often see is this mucopurulent cervical discharge in women with hypertrophy, erythema, and edema of surrounding tissues. This chlamydial infections can also lead to infections that travel up the uterus into the fallopian tubes and can cause fallopian tube damage and scarring. In men, symptoms include urethritis, so that's inflammation of the urethra, meatal erythema and tenderness, purulent penile discharge, and urethral itching. Men can also develop prostatitis and epididymitis, which can lead to infertility. There are some serious complications of untreated chlamydial infections. The most common one is something called Reiter syndrome, where we see a triad of urethritis, so inflammation of the urethra, conjunctivitis, inflammation of the eyes, and arthritis of weight-bearing joints. So those three things together might indicate a serious complication of untreated chlamydial infection. We have many diagnostic methods of chlamydia. There's two long paragraphs in your book. Just know that there are a lot of different ways to diagnose chlamydia. And treatment is typically with azithromycin or doxycycline are the two drugs of choice right now. And again, this is usually a pretty curable infection with antibiotic treatment. Gonorrhea is caused by a bacterium and gonorrhea. Humans are the only natural host, and the rates of infection are highest among men ages 20 to 24. It likes to grow in warm, mucus-secreting epithelia, so genital environments are a perfect situation for gonorrhea. Its portal of entry is either through the genitourinary tract, through the eyes, oropharynx, anal rectum, or even through the skin if there are abrasions to the skin. Transmission is usually by either heterosexual or homosexual intercourse, but it can also be transmitted perinatally through birth. And its incubation period is typically about 2 to 7 days from infection to symptoms. If left untreated, gonorrhea can spread from its initial sites upward into the genital tract. In men, it can spread to the prostate and epididymis. In women, it can produce endometriotitis, salpingitis, and PID, so inflammation of the uterus, fallopian tubes, and pelvic inflammatory disease. So clinical manifestations, diagnosis, and treatment. Men experience things like urethral pain and creamy yellow, sometimes bloody penile discharge. and it can become chronic, affecting the prostate, epididymis, and periurethral glands. In women, we see genital or urinary discharge, dysuria, meaning painful urination, dyspareunia, which is painful sexual intercourse. They can develop pelvic pain, unusual vaginal bleeding, and fever and proctitis. That is inflammation and itching of the anal canal. Chronic infections can occur in the fallopian tubes that can lead to things like scarring and sterility. We diagnose gonorrhea by culture because of its potential for spread and uh, causing complications in pregnancy. We do routine screening for gonorrhea in pregnant women. There are also many resistant strains that have developed of gonorrhea. So we've seen a lot of changes to the overall treatment strategies that we use for gonorrhea because of the development of resistant strains. So the current recommendations are dual therapy with ceftriaxone and azithromycin. And finally, we're going to talk about syphilis, or Treponema pallidum is the infectious agent here. Also bacterial, spread with syphilis. This is a disease that we saw rates drop significantly, but now seeing them really on the rise. Highest rates are typically found in men ages 25 to 29. The other thing to know about syphilis is it has a very kind of rapid transplacental transmission. And I think this happens around 16 weeks of gestation, where the syphilis infection is able to very quickly cross the placenta and infect the fetus. And this can produce congenital syphilis with potential congenital deformities in the baby. So things like prematurity, stillbirth, and congenital defects can occur with untreated syphilis during pregnancy. So just like gonorrhea and HIV, we do test for syphilis as a screening method in all pregnancies. So the clinical manifestations of syphilis happens really in kind of three potential stages. So primary syphilis is the initial phase right after infection. So usually what happens is there's this appearance of what we call a canker at the site of exposure. Cankers typically appear within an average of about 3 weeks of exposure to the virus, but they can incubate for up to 3 months. The primary canker begins as kind of a single indurated, so it's kind of sunken in papule that's up to maybe several centimeters in diameter. And it erodes to create kind of this clean-based ulcerated lesion on an elevated base. So that's sort of what that lesion looks like. There is a picture of one in your reading, but they're pretty distinctive. They are solitary, so there's just usually one, and they have this really discrete raised border. They're usually painless lesions, and they're located right at the site of sexual contact. Because they're painless and they vary in size, someone may not even notice this initial presentation. They may not ever even see that they've developed this canker. And unfortunately, at the stage where that ulceration is developed, this is kind of the most highly contagious stage, but again, also commonly unnoticed. So that's primary syphilis. In secondary syphilis, this stage can last anywhere from 1 week to 6 months. Symptoms in secondary syphilis include a rash. There are a lot of different areas this rash can form, but one of the common spots where we see it is on the palms of the hands. Patients also develop things like fever, sore throat, stomatitis, so that's inflammation of the mouth. They also can get nausea, loss of appetite, and inflammation of the eyes. Post-secondary syphilis, this disease also often enters kind of a latency phase where it goes dormant within the body and not causing any kind of signs and symptoms. But then it can reemerge in this kind of tertiary syphilis response. So this is a delayed response of untreated syphilis, and this delayed response can take decades even to occur. And the signs and symptoms we see with tertiary syphilis are gummas, which I'll talk about in a moment, cardiovascular lesions, and central nervous system lesions. So a little more about tertiary syphilis. So gummas are these kind of peculiar rubbery necrotic lesions that can appear at various places on the body. They can vary in size and number. Liver, testes, and bone are some common places where we might find gumma, but we can also find it on kind of the skin. The picture you see here is someone who has developed syphilis-related gumma on their face. And as we mentioned, these are what we call necrotic lesions. So they eat away at and destroy the underlying tissue. So you can see here that the gumma has affected the nose, and it has essentially kind of eaten away at all that tissue of the nose itself, kind of leaving that area just really exposed. Prior to treatment with syphilis, you can Google these pictures if you want, but prior to good syphilis treatment, people with syphilis would have kind of these really distinctive kind of facial deformities because of it. The CNS lesions that can develop in tertiary syphilis can cause things like dementia, blindness, and spinal cord injury. That can lead to ataxia, which is abnormal body movements, kind of abnormal, uncoordinated body movements, and sensory loss. And the CV manifestations are caused by scarring of the thoracic aorta with aneurysm formation, and this often leads to aortic valve insufficiency as well. So diagnosis and treatment of syphilis. Syphilis tends to be really hard to culture, so we often diagnose through things like serologic testing for antibodies of syphilis. We often repeat test, even if someone is initially negative for syphilis, but if they have a high probability of exposure. Because it has a really long incubation period, we do run the risk of getting false negatives during early infection, so repeat testing might be necessary. And treatment here is with long-acting penicillins, including concurrent treatment of any sexual partners, even if they're asymptomatic, because again, many are asymptomatic or don't notice that initial onset of syphilis infection. But this is very curable with the use of these long-acting penicillins.